postdoc at the same time as my residency when I was at the SHRM. So this was a project that was led by Dr. Menal, Cynthia Menal. She's a chief radonc at the SHRM, and she came over from the PMH. So she had this project that she had started at the PMH. So she already had all her collaborators lined up and everything. And it was a project to create a probability map of recurrences of prostate cancer after prostatectomy, after the prostate had already been removed. So just a few background facts about prostate cancer and what happens after prostatectomy. So most cases of prostate cancer are diagnosed at an early stage now, where the disease is confined to the prostate. When after following diagnosis, there's two kind of main treatment options. So there's active surveillance, where you keep doing blood tests and imaging and to make sure that the disease is not progressing, or you can straight up do a radical prostatectomy, a surgery to remove the prostate. And often now what people will do is they will do active surveillance, and then as soon as they detect any progression of disease, then they move on to the surgery. After the surgery, there's about 15 to 25% of patients who will develop what we call a biochemical recurrence. And that's when there's a rise in the PSA, the prostate-specific antigen, which is a protein that's correlated with tumor growth. So basically, it's defined as when the PSA is greater than 0.2 nanogram per milliliter on 2 readings. And when that happens, then the patient has a biochemical recurrence. So the way we use radiotherapy to treat patients post prostatectomy is usually if the patient has adverse pathologic features. So basically, once they remove the prostate, they find disease on the margins, let's say, or at the first sign of PSA recurrence, then there have been all these clinical trials that have shown that external beam radiotherapy can reduce the risk of recurrence and can control the disease. So typically, there's two types of postoperative external beam radiotherapy. There's the adjuvant kind, which is given right after surgery, and that's usually if there's adverse pathologic features. So if there's positive margins, or if there's other, like maybe in the Gleason score, or some other clinical indication that the patient could benefit from radiotherapy right after the surgery, but it's rarely used nowadays, from what I understand. Only higher risk patients, and only 7% of overall patients. Whereas the other option is salvage radiotherapy, and that's when after the surgery you keep monitoring the PSA, and you wait until there's a detectable rise in PSA before you decide to give the radiotherapy. So immediately following a rise in PSA or biochemical recurrence, often the disease is not detectable by any imaging or it's microscopic disease, so there's no biopsy. So basically, you don't know where the disease is, and the current practice is to kind of treat a larger area, but then that leads to more side effects. And there's currently still, so these are papers published in 2023, which shows that it's still a huge topic of debate currently. So there's one study that was just showing that salvage radiotherapy is indeed effective. in patients where the disease is not visible on PET images. So they did a retrospective study, and basically they conclude by saying that the results support the current recommendation to initiate salvage radiotherapy in a timely manner after detecting biochemical recurrence, even in patients whose PET imaging is negative. And then this other paper is basically a guideline that was based on experts delineating disease. And it's a guideline on how to draw the area that you're treating, the CTV. So what they found in going through this process of trying to establish some consensus guidelines is that there is a lot of variability in the current guidelines, and this is Astro, and then the Americans have their own I forget I'm blanking out on the name, but yeah, and then basically yeah, so what they do with these is they do use they do use imaging that detect disease, and then they come to a consensus. They have experts delineate the disease on all these different images, and then they come to a consensus on how they should draw the CTV. And so yeah, so it's basically based on radio-oncologists contouring disease, and then they apply these contours to patients whose images are not positive. So yeah, yeah, the RTOG. Sorry. Basically, that's the idea. Is that if we could have a 3D heat map of recurrence probabilities, then it would help and assist. It would assist in drawing the PTV and potentially even doing dose painting, having different dose levels, and boosting the areas that are more likely to have disease. So yeah, yeah, and the other thing is so these studies were published this year, and before that, the previous consensus that most people followed was from 2010, and it was from the RTOG. They had it was a similar thing. They assembled a panel of experts, and they used CT, MR, and clinical indications to come to a consensus CTV. But then there have been studies since then that report anywhere from 30% to 60% of the recurrences that they're treating were not covered by the consensus CTV. And so that's why since then there's been more activity in trying to come up with a better way of coming up with a way to draw the CTV. So I'm going to be talking a lot about PSMA PET imaging. So that's a novel modality. That's the most sensitive test for the sensitive imaging method for detecting prostate cancer recurrences. And so the idea is to use the recurrences that you find on these images to base yourself on these images in order to pick your map. So PSMA is prostate-specific membrane antigen. Its expression correlates with tumor aggressiveness metrics. So it uses a novel PET tracer. For example, there's a gallium-68 PET tracer. Yeah, so studies have shown higher sensitivity and specificity compared to other imaging modalities, including multiparametric MRI. And then, and retrospective studies of outcomes have also shown that when you use this imaging modality to guide your salvage radiotherapy, that can be an effective treatment option. So the idea is to start from these images and build a 3D map of recurrences from a large pool of patients. So there's this work, this similar idea has already been done by a couple other people. So one of them was a group led by Schiller. They presented the first map of recurrences. They had 233 patients. They concluded that the vast majority of the lymph nodes were not covered by the consensus CTV, even though in the prostate bed it was mostly covered. So what they did was they took different patients, they registered them using rigid and deformable image registration tools. Basically what we're proposing is to set up a pipeline where we use a better deformable image registration tool, which I'll talk about shortly. And then there's this other group that presented an abstract at Astro. So they haven't published this yet, but they also have about 200 patients. In the abstract, so they mentioned that the CTVs were all controlled manually by Radox, but they don't mention how the images were registered to each other to create the map. And so that brings into question the accuracy of the map that they had. So we'll have to wait for their publication to find out more details. But for now, so this project called Portray, it was started, I think, in 2019. It's a pretty big collaboration with multiple institutions because you need to acquire a lot of data. And that it turns out that that's the step that takes by far the longest. It takes years to get people to sign the contracts and send the data and so on. So far we have about 250 data sets, and then we're waiting on another 100 from this American company. So the contract has been signed, but it's in legal hell for the past 2 years. And then it's also a collaboration with Christy Brock's group at MD Anderson, because they're developing the deformable registration tools, and also they provided the trained AI segmentation models in RayStation, which I'll get to why we need that. And yeah, basically the idea is just to reiterate. So you have some PET CT images with positive disease. You perform deformable registration to put them all on the same reference frame, and then eventually you could take this map and you could perform again deformable registration onto specific patients to see where the disease would be, and hopefully that'll help guide how we draw the CT. So the first step of the project, as I've been saying, is to come up with this map using a hopefully larger data sets and improved image registration methods to improve the accuracy. But when I was reading the grants, the real long-term pie in the sky objective is to not just have this map that's like an average of the recurrence probabilities, but to also incorporate patient-specific data using machine learning in order to tailor this map, to further tailor its individual patients. So some examples of the data that you could use to correlate to the location of the disease It's just things like patient age, sites of recurrence on the imaging, obviously. The PSA at the time of imaging, but also the PSA doubling time, the resection margin, and so on and so forth. A bunch of clinical data that we could, in principle, use to try and to say, well, this patient has this grade, so that makes it more likely for the disease to be in this area, and so on. That's really the next level. For now, we don't really have all of this full data from all the patients. So there's a PhD student who started this year in her group, and that's going to be his PhD project. He's going to have to figure out where to get the data. So yeah. Okay, so the deformable image registration is the core tool that we need for this project. So it's basically, I'm sure you're all familiar with what it is. It's just to register a patient onto a reference anatomy, so that we can add up all of the diseases on the same anatomy. So in order to compute a registration, first you have to choose some kind of similarity metric or difference metric. So it can be least squares or cross correlation or neutral information. And then you optimize this metric by either maximizing the similarity between two anatomies, or minimizing the difference. And then you have this iterative process where you update your deformable deformation vector field for the transformation of your image until you get something that you're happy with. So in general, there's two kind of broad categories. There's intensity-based and there's feature-based. Intensity-based methods are different registration methods where the similarity metrics are just based on comparing individual pixel or voxel intensities. So you go pixel by pixel, you can look at, for example, the sum of squared, the difference in the sum of squared, and then minimize that. However, it's sensitive to noise. So if you have a low contrast region where the pixel values are all very similar to each other, then this, minimizing the square of the difference in the pixel value is not going to be a good way to, it's not going to give you good results. And also, if you're just looking at individual pixels and ignoring the regions, the anatomy of the patient, then you can't guarantee any kind of anatomical reasonableness. Basically, the first paper that came up with the map, the Schiller group, they used a plastic match model, which was only based on intensities. So that's why we think there's room for improvement. The other category, the feature-based, is basically the similarity metrics are defined based on surfaces, curves, or points that are relevant to structures that are defined in both image sets. So this allows you to end up with anatomically reasonable deformations close to the features that you select. However, this also has its own issues. So the selection of the features can be, well, it's subjective and somewhat arbitrary. And depending on which features you select, you end up with different deformations. And there's no ground truth or anything. You have to kind of quantify the uncertainty that you get from the selection of features. And also the other issue is that they don't provide any information in the regions where you don't have any features. So in those regions, often you get nonsensical deformations. And I'll show you an example later of that. So in Raystation, they have this, I think it was developed by a Swedish group, and it's called Anaconda, and it's a hybrid method. So in this method, the objective function includes both the intensity, like the pixel values, but also this information about structure. So you can, so it's based on both. It has the benefits of both approaches, and manages to avoid some of the drawbacks. It also contains regularization terms in the cost function, which ensure that the deformation vector field is smooth and invertible, and that the deformation is anatomically reasonable. And so this is the method that we're using for this project. So because it's a hybrid method that requires structures to be delineated on both target and the reference data sets, we need to have contours for these structures. So basically, we need structures in the pelvis that are close to the typical location of the recurrences. The recurrences are usually in the prostate bed and in the lymph nodes. And so we need the bladder, the rectum. And then for the lymph nodes, when we first started with this project, we were trying to figure out how do we segment lymph nodes for some kind of surrogates. And well, using the iliac arteries and veins would be good because they pretty much follow the lymph nodes. So that would be like a good surrogate. And then bones also. So we have hundreds of these image sets that we need to segment. I'm not going to do it by hand. So obviously that's why we need the AI segmentation part. Yeah, this is just like an image showing how the registration is a lot more accurate when you include the bladder as a controlling structure in this example. So we were in yeah, so that's the idea. So for example, this is what the anatomy sort of looks like. You have in pink, these are contour recurrences, and every patient has, you know, veins and arteries that look quite different, and also the bladder filling is very different. And so we need to apply some kind of deformation onto a reference anatomy to map these recurrences. So that was a workflow that we had. You start off with our PSMA PET CT images. We contour. So initially we had to contour subsets by hand in order to feed it to our deep learning segmentation models. And then once we use these models, we correct the contours by hand, and we repeat this loop until the contours are good enough. And then we can use these structures to compute the deformable registration and sum up the deformed recurrences and get a map. And the recurrences, of course, have to be contoured by hand, ideally by radiologists, but we didn't have a radiologist on the project, so I had to base myself on their notes to do this, and it wasn't always self-evident. And all of this was performed in Raystation. Yeah, so for the deep learning image segmentation, we were in luck. Well, it wasn't luck. Christy Rock's group, they already had some models that were previously trained, but on the female pelvis dataset. And why female? Because these are post-prostatectomy patients. So the prostate is not there, so it's actually more similar to a female anatomy. And we basically just had to retrain these models. So the models were already quite good for the bladder and the rectum, but they didn't have anything for the vessels. The blood vessels are not something that's commonly contoured. It's kind of strange to have to do that. Not strange, but rare. So that's why we had to retrain these models on our data sets. They had a 2D model based on Google Flat and a 3D model that was a units model that was implemented in Race Station. So just to give you an example of, or give you a taste of how annoying the segmentation of these vessels were. So if you look at the image on the left, you know, how can you tell what is a vessel, or like what is an artery and what is a vein? You know, like the registration, the segmentation algorithm came up with what's on the right, but you know, just at first glance, it's pretty hard to distinguish anything. But basically, it's not as bad in practice. Like when you scroll through the slices, you can kind of follow the tubular shape, and also you know, certain features like arteries will tend to have like calcifications, so these bright spots and vein stars. And arteries tend to be more circular, and veins get squished into all kinds of shapes, stuff like that. And you use, you know, it's a labor-intensive process. So it definitely had to be done by using the AI model and not by hand for 200, 300 patients. Surprisingly, actually, we trained from 30 patients. They had 2 data sets each because there were patients who were treated at the shim, so they had the planning CT on top of the diagnostic PSMA PET CT. So after only 30 patients, the 2D model was not great, but the 3D model was getting pretty close. And for a while, we tried to make it perfect until we realized that maybe they don't have to be perfect. So I started doing some tests by seeing, so if the recurrence was close to a defect in the vessels versus if it was far from a defect in the vessels, what kind of impact that would have on the location of the formed recurrence. So as you can see, this is an example where it's right next to a section of the vein that's missing. So this is a corrected, I manually corrected the contours. And you can see that the difference in propagated contours was up to 4 to 5 millimeters, which was a little bit big, bigger than we had hoped for. Whereas in this other example, it's the contours still had defects in them, but the recurrence was far from those defects. And so you can see that it makes no difference. And in hindsight, that's intuitive and kind of obvious. So basically, it doesn't matter if the vessels have sections that are missing, or sometimes it swaps the vein and the artery. As long as your recurrence is not close to those defects, you were good. And it turns out most recurrences are not close to defects. So I only had to modify, this is just another example. So I only had to manually go in and edit the regions and vessels that were close to the defects. And so I did this, I think in 2021 up until last year, sometime last year. And then at the end of last year, there was a commercial software that became available from Varian with Siemens called Organs RT. And basically, it can just contour everything in the body. It doesn't do the vessels because nobody needs the vessels. but it does something even better, which is it straight up contours all of the lymph node regions. It even breaks them down by, common iliac, internal iliac, external, obturator nodes, and so on. It basically contours all of the lymph node regions. I don't know if you can see them here, so it's a bit pale. But yeah, and so when Cynthia saw this, she got very excited. And so we had to incorporate these contours into our deformable registration. And so at this point right now, we basically have all of the recurrences contoured. We have all the structures that we need to do the deformable registration. So we started doing a lot more. We started systematically going through all of our patients. And we ran into some practical challenges with deformable registration. So first off is that, like I mentioned already, which structures you select can change the location of and also the shape of the deformed recurrences. So because so different depending on the location of the recurrence, we would it takes a human to kind of say, I want to include the following structures, and sometimes it's ambiguous. So you don't so you know that if you selected the bones or not the bones, then you would end up with something slightly different. And so there's always this inherent uncertainty. And so we thought, well, we could account for this by having an uncertainty margin, and we would blur the edge of the recurrence when we create the map. So that's one thing. And then there are other limitations, like in these examples here. So our reference patients is not a small, but yeah, our reference patient is not a 400-pound patient. So if you have bigger patients, when you try to do the deformable registration, let's say you select the lymph nodes and the bones, which are all kind of in the center here. The registration algorithm doesn't know how to compress all of that extra volume down into onto the reference patient. So you end up with these really really funnily shaped body contours. But for us, I think that's not a major issue, since all of the recurrences are pretty central. But it is something that we noticed, and we chatted with the people at MD Anderson, and they said, well, we could look into the scripts, but sometimes there are these limitations, and we might not be able to solve this. And also, depending on I'm not showing pictures, but some centers have the patient's bladder being empty, and other centers have the bladders be full. So when you do whenever you have large changes in volume, in shape, and so on, it kind of distorts the anatomy around it into something that doesn't really make sense. Yeah, so basically those are some of the issues that we've been having, but we're making good progress in building this map. So we have close to 300 patient data sets, and potentially another 100 if we want to wait another, not sure how long. All the recurrences for the patients that we have been contoured manually, and then all the vessel contours that have defects post the recurrences have been corrected. We've imported all of the lymph node contours from Holding RT, and we're in the process of coming up with the uncertainty estimates for from using different structures during the registration. Yeah, ultimately, we would like to keep the error in propagated recurrences to be less than 2 to 3 millimeters. So yeah, the previous studies, they didn't have any kind of estimate for this uncertainty. They just went with the simplest tools. So we're trying to do a bit better. So that's it. I'd like to acknowledge all the people who have been involved, all the people who gave us data. And also the grants that we've had in my past accelerate the Prostate Cancer Canada grants. That's where we're at.